Well, thanks for being with us. I'm just going to give everyone a brief bio sketch of you. Dr. Anthony Margherita attended the Georgetown University School of Medicine in Washington, D.C., and received his MD in 1985. He is a graduate of the Physical Medicine and Rehabilitation Residency at the University of California at Davis in 1989. He is certified by the American Board of Physical Medicine and Rehabilitation. He was on the faculty of the Department of Rehabilitation Medicine at the University of Washington from 1989 to 1997, and the faculty at Washington University in St. Louis from 1997 through 2003. He lectures locally, regionally, and at the national level on spine, sports, and musculoskeletal medicine and pain mechanisms. His current research interests include physical and functional capacity testing and injury surveillance in sports. He has participated in over 75 clinical research trials. His clinical interest and his clinical skills and expertise resulted in his being honored as being among the best doctors in America for the past 16 straight years. He has been a study section panelist for the National Institutes of Health, research review panelist for the National Institutes for Disability and Rehabilitation Research, and has served as an international advisory editor for the International Encyclopedia of Disability. Thank you again so much for being with us.
My pleasure.
Well, I think you're going to share your desktop with us and give the presentation. So, Journey, if you wouldn't mind making him the host, giving him that little presenter ball. You can just drag it. You can just drag it to him. There it is. And Dr. Margherita, you now have the ability to share your desktop with us.
Okay.
Oh.
There we go. Oops. Let's see. There we are. Okay, there we are. Okay. Excellent. Let me just make sure that this shows. Is that showing okay on your screens?
Yes, it looks great.
Okay, great. So our topic for today is something that I happen to see very regular in my clinic, and that is people who complain of basically pains in the butt that are not necessarily due to a spouse or a significant other. So I know that you guys have been really focusing on diagnostic error and diagnostic accuracy, and what I've done is sort of taken this lecture and really modified it a little bit so that we can talk about cases and talk a little bit about sort of what's important when evaluating a patient and how diagnostic error really comes into play. So we'll go ahead and get started, and I'll give you a couple of quick disclaimers. First, I don't consider myself an expert. I think we're all in the process of learning. I learn things every day from my patients and from the people that I work with. And second, to err is human, but the more you know, the less you err. And that really is the essence of what I teach residents and medical students and whatnot. I have a little rule that I use with my students, and I say, if you know where it goes and you know how it works and you know the anatomy, the physiology, and the motion, you've got a lot of diagnoses under your belt when you evaluate a patient. Those of you that have seen some of my interconsults will know that I harp a lot about evaluating and physical examination and figuring out what's going on. And sometimes the source of the problem is fairly straightforward and fairly easy. I think in this case you could identify the inciting event or trauma relatively easily. But sometimes we have, you've got contextual aspects of a patient who's coming in with their complaints, and this is just a quick one to realize that not always is it exactly clear what the person's complaints are relative to what their contextual situation might be. So there are a multiplicity of reasons for people to come in with buttock pain. So and as a result, there are a lot of ways to go astray when evaluating that person diagnostically. One of the things that I do in my practice and that I see on a pretty regular basis are patients that have been seen by other physicians, other providers in wide-ranging specialties that have tried to evaluate whatever that person's condition is. When they come in to see me, it's actually relatively straightforward once you know the anatomy and what they're really presenting with, and we'll go through cases that will give us some information in that regard. The common adage in medicine is the mystery is in the history, but I would argue that it remains unsolved without the examination. So when you have seen my interconsults, you'll see that oftentimes one of the first treatment recommendations that I will put into a report is that the patient have a reasonable, appropriate, comprehensive, well-structured examination to help identify what that person's pathology might be. And sometimes we use pain diagrams and things of that sort to identify where the patient's problem is. And as I'm sure you can see, let me see if I can get my arrow here. Okay. You can see in this person, it's going to be much more difficult to identify a true pain generator when they've got pain that's circled, if you look over here, I like to call that extracorporeal pain. That's where the person describes pain that's outside their body. Whereas in this case, you have a fellow here who's got radiation along the buttock, along the posterior thigh, extending maybe to the calf. This is a person who's going to have a very straightforward, very easy diagnosis, and you're going to be able to proceed forward. This case is going to be a lot more difficult to, the case on the left is going to be a lot more difficult to really figure out. So there are a variety of structures that we need to consider when evaluating a person who's got complaints of buttock pain or radiating pain to the buttock. Obviously, the lumbar spine is a very common factor. The sacrum or the sacrococcygeal area, the sacroiliac joint, which is a very complicated joint. We'll talk about that in a minute. The hip and lower extremity, and some of the various pelvic structures. And our cases today are basically going to go over each of these different areas and how they contribute. Now, I'm going to share with you a couple of things that you may not hear when you talk to your more traditional medical providers, and that is that human motion and human biomechanics is exceedingly complicated. And just to give you a little bit of an example, the human body is obviously multi-segmented. It's how we move. The number of skeletal levers, the number of muscle activation patterns, the combination of muscle activation patterns, all come into play in a person who's having a report of any type of musculoskeletal condition, whether it be a hip or a buttock or a knee or a shoulder or whatever it might be, and that those segments interact in a very sort of almost like a complicated dance that coordinates motion. And if one piece of the puzzle goes awry, that person is at risk to develop symptomatology. Just to give you a little better example of that, from a biomechanical perspective in the lower extremity, if any of you remember your high school or college physics, we talk about degrees of freedom. Well, there are 54 muscles in the lower limb with 23 degrees of freedom. You'd have to basically use essentially a supercomputer to really be able to calculate the forces in any truly coherent way. So anytime that I see a patient, what I'm doing is I'm trying to take in a gestalt of what that movement pattern is, what that person's mechanics are, how that joint is moving versus how its muscular supports are operating or how they're functioning. And I'll give you one example here. The sacroiliac joint is a very complicated joint. The examination is complicated. There are at least 16 different exam techniques that are used to evaluate the sacroiliac joint. But a friend of mine and colleague, Dr. Joseph Fortin, back in the 1990s, actually wrote a paper that identified that among the most accurate tests that you can use when evaluating a patient with a sacroiliac joint problem is to ask them to point one finger. It's called the Fortin finger test. They actually point one finger directly to where their pain is. And if they point specifically to the sacroiliac joint, well, that's where the problem is potentially present. The other issue with regard to the sacroiliac joint is that the SI joint is only accessible on the posterior side. I can only examine that person from the back because the front of the sacroiliac joint is basically the pelvic content. So you can't really examine it other than accessing it indirectly in some respects from the back side. To give you a little even more complicated way to think about things, the way that these movement patterns occur are very much based on what the movement consists of. And the hamstring is a great example. If you look at the hamstring, the way the hamstring works is that it activates and this is just during gait, just when you're walking. So, you know, when you get up to grab a glass of water during this presentation, or whatever it might be, basically your hamstring activates in a shortening way, in a concentric way, during initial swing phase. So when your leg is swinging through space to induce knee flexion, it flexes the knee. However, in late swing phase, when your leg is swinging, getting ready to hit the ground, it activates eccentrically. So it actually fires at a higher tensile load to control knee extension, so your knee doesn't hyperextend when you hit the ground. And then during stance, when your foot is actually on the ground, it doesn't do anything at the knee. It actually works at the hip. It acts as a hip extensor when we have what's called a closed kinetic chain, when the leg is on the ground and there is there's a contact point that is essentially immobile. So we've gone over a little bit of how complex and how multifactorial the evaluation needs to be. Let's briefly talk a little bit about diagnostic tools. One of the things that I always say is that I treat patients, not pictures. There have been well-done studies. Scott Bowden, some years ago, I think it was 1990, published 2 papers with regard to the neck and with regard to the low back, where they took 100 patients and they put them through MRI scanners, and 40% of individuals over the age of 40 had identifiable pathology on MRI scans, but had absolutely no symptoms whatsoever. So you have to take imaging studies in context with what that person's history is and what their examination shows. So we use MRI imaging very commonly. Unfortunately, many of my colleagues use an MRI as a substitute for a physical examination, and that can be problematic. It's great for identifying soft tissues. It's great for looking at things like disc herniations and things of that sort, and you can kind of see that on this. In this case, there's a disc herniation right about there. CT imaging, although it's a high X-ray load, gives very good diagnostic assessment of bony structures. So if there's a situation where there actually is bony pathology, and in this case you see some arrows, it's a little fuzzy, but you see some arrows here and here at number 5 and number 6 on the slide that actually identify that this individual has a fracture across the pars interarticularis. For some patients, the diagnostic accuracy is enhanced through the use of myelography, which is dye that's injected into the spine. Now, a modality that's not as well utilized or not as extensively utilized is Spect Imaging, and this is basically a fancy 3-dimensional bone scan. So if those of you that have seen bone scans in the past, this is a bone scan that's basically done with the scanner, the camera basically spinning around the patient, creating a 3-dimensional image. So this image where you see this blue arrow, I can actually rotate it on screen in 360 degrees and identify that those big white spots that you see are areas where this person has inflamed or irritated facet joints. As a physiatrist, I do a lot of electrodiagnostic testing, and what you see below on the little graph there these are the type of findings that we see, the abnormalities that we see. You see the various arrows. At the top, the arrows point to what we call positive sharp waves, and the arrows down below point to what are called formulation potentials. These are abnormalities that are found within the muscle when it has lost a portion of its nerve supply. So when a patient comes in and I'm testing them, basically I'm figuring out what, where, and how bad. Where is the pathology? What nerve is it in relation to? And how bad off is that person relative to abnormalities in their spine or lower limb. It has very good sensitivity and excellent specificity with regard to nerve lesions. It can be combined with nerve conduction testing to confirm that a person doesn't have a neuropathy or some other peripheral nerve lesion or a lumbar plexus lesion or things of that sort. And there's a test called an H-reflex that, frankly, I don't do a great deal of because I don't find it that useful, but it can be used basically as an electrical equivalent to doing a deep tendon reflex. One thing I will point out is that when you review cases or if you see cases that come through where there's testing, if there's a lot of F-wave studies, which is basically a technique where a signal is actually generated up to the spine and then sort of bounces back, F-wave studies are generally not all that useful unless you're evaluating a condition like the lumbar plexus or the brachial plexus, and really don't add very much to diagnostic accuracy. So let's go ahead and move on and talk a little bit about cases, because I want to make sure that we've got time for questions at the end. So when we look at cases, right, we always say, do you hear the hoofbeats? And the question, is it a horse or is it a zebra? So let's go ahead and talk about our first case. The first case is a 28-year-old woman, 6 weeks postpartum, with left buttock and leg pain. She has radiation into the posterior leg, no back complaints. She saw her primary care physician during the 3rd trimester of her pregnancy. She also sought the assistance of her OB. She was given a diagnosis of sciatica, but her MRI was completely normal. She was recommended to physical therapy, but heard about our clinic and came in about 6 weeks later. So her examination was quite impressive. She could hardly bear weight on her left leg as she entered the exam room. She was in obvious pain. She could not sit easily in the exam room. She had weakness in muscles below the knee, so she had what almost appeared to be a foot drop, although it was difficult to tell because she could bear so little weight on her leg. She had no back pain complaints at all. And when I took her, laying on the exam table, flexed her hip to 90 degrees and then adducted it, drew it across the midline, she literally screamed when I put my finger deep into the tissues of the buttock. I felt that it was important that this woman be evaluated because she had no back pain. She had no real spine findings at all. She had a normal MRI, so we chose to do an MRI of her pelvis. This woman had a tumor. She had a tumor that you can see in the bottom left. I'll see if I can go here with my arrow. This is outlining a tumor that is basically enveloping her piriformis muscle and essentially squeezing her sciatic nerve. Fortunately, it was a benign tumor. It was resected. The pathology came back, and it was what we call a hydatiform mole, which is a very, very, very unusual type of presentation. The bottom line, though, is that this is a case of someone who was, not diagnosed because the imaging study was not appropriate to where her pathology was. There really weren't any good examinations, and it just took a combination of those two to identify her pathology, identify her lesion. So here's our second case, and there are actually two cases that are very similar. Two middle-aged men, both sustained falls, acute severe localized pain, nothing distal, meaning nothing into the further down into the legs. Initial MRI scans were read as quote-unquote degenerative in nature, and plain x-rays were normal at the time of the initial event. These were both injured workers. They were treated at an urgent care type of facility. Now they're being seen 3 weeks, 4 weeks out with persistent symptoms. So both have very restricted range of motion on their examinations. Neither of them had any neural tension signs or any evidence of any distal pathology, but both had significant vibratory tenderness. And what I do is basically take a 128 tuning fork and put it over the bony structures and determine if the patient if they describe pain and not just vibration. So here's the first case. This is a fellow who basically landed on his ass, and he sustained a fracture of his S2 vertebrae. The S2 vertebrae is right here. You can see the slight displacement forward. Unfortunately, there's not much you can do about that. So we placed him in a donut. We limited his activities, and basically just to let this thing heal. It took about, I want to say, about 9 or 10 weeks for him to get back to reasonable activity. The second case is a little more complicated. The second case, on follow-up X-rays, showed some pathology. And what you see here in the darkened area, that's a wedge compression fracture. So this fellow had a fracture that was not identified on his initial imaging because it collapsed over time. So his original report was of degenerative pathology because they saw what we call reactive end plate changes or swelling in the bone, when in point of fact that swelling was because he was just beginning to fracture. So the first case we treated just expectantly and didn't really do very much. The second case, however, really showed evidence consistent with a compression fracture and ended up requiring cement. We did a vertebroplasty on this fellow, and I'm happy to say he had virtually complete resolution within 3 to 4 weeks of the cement. Our third case is a fellow who works on a loading dock. He's had multiple prior strain injuries described basically into his low back and buttock. His pain is worse with extension, with bending backwards. This guy had seen, I don't know how many people, a lot of different people. No neurologic deficits. People said that he just had a muscle strain. They told him that he, needed to do exercise. They probably told him he needed to lose weight. He had a few extra pounds on him. He went through the whole therapy thing, not really making very much progress. And he had no symptoms on flexion with examination, but severe pain in extension and rotation. So having him bend backwards and then rotating his shoulder towards the symptomatic right side. Again, he had no neural tension, no other significant findings, and his neurological exam was completely normal. Well, one of the things that's very important when evaluating a patient is to do the right type of radiographic studies. So this fellow had an anatomic variation that's called the Bertolotti Syndrome. And that arrow points to, it's a little hard for you to tell. You might be able to see it on screen, but there's a very faint line that's right here. I hope you can see it with my cursor. There's a very faint line that represents a pseudo-articulation. I'll show you the CAT scan version of this in a second. The CT is actually where this arrow is pointing right here. So this line right here, you see that there's the vertebrae extends here, but then on this side it extends all the way out. Sorry, the arrow actually kind of covers it a little bit, but this area right here is where the Bertolotti's is. It represents a partial sacralization of the L5 vertebrae. I actually think the treatment slide gives a better picture. I'll show that in a second. But this represents basically an abnormal articulation. This fellow was getting pain because he was old enough and he had started to degenerate enough that he was beginning to get arthritic in this joint. And that was what was producing his symptoms. And I'll show you, this is actually a good picture. That's the same as the one before, and you can see the articulation right there. So he was diagnosed with Bertolotti Syndrome with acute arthropathy. By the way, this thing lit up like a Christmas tree on his SPECT scan. So he had a diagnostic injection to be sure that that was a pain generator. He had complete resolution of his symptoms. We ended up injecting him with a steroid and then taught him some stabilization exercises, and he was able to return to his usual activities. Our fourth case, a 67-year-old auto worker back in buttock pain after a motor vehicle accident. This fellow was delivering a vehicle, was kind of twisted, I guess, getting out of his vehicle, I think, was hit from behind by a vehicle coming off of the highway. No prior history of lumbar spine issues or any other problems, but a reported history of arthritis for which he had been treated with anti-inflammatory medications. This fellow had very specific pain with lateral bending, which is a little bit unusual when you do a physical examination. It's not one of the things that you usually see, but he had some flexion pain, but much more pain with extension. What would happen is when you would extend him backwards, he would actually get a shooting radiation all the way down his buttock into the posterior thigh. He had no neurologic deficits that we could identify. Now, what was interesting about this fellow is that he has a spondylolisthesis, which means a vertebral slippage, and you can see the slippage right here. But what's actually more important is that you see on the image to the right that this black protrusion coming from the joint. He actually had what we call a synovial cyst. So he had some arthritis in his joint, probably secondary to the spondylolisthesis because of the slippage. And what happened is a cyst formed in the joint. That's the reason why he was having lateral bending symptoms, and it's the reason why he was having pain with extension, because as he extended, the cyst was getting pushed into his nerve. So this fellow was diagnosed with a synovial cyst, a nerve compression. It was aspirated under fluoroscopy, and then it was injected. The joint was injected with a steroid medication. Now, this fellow did actually quite well. His cyst did not return. Sometimes they do return and they have to be surgically resected. They have to be taken out. But one of the important things that I think my colleagues sometimes miss is the fact that these spondylolisthesis situations can progress with time. So this fellow needed to be monitored over a period of really a few years to be certain that that spondylolisthesis would not progress. Our fifth case is a 16-year-old. This is a fellow who just finished cross-country season and was now moving to play basketball. So he is trying to play basketball, and when he runs up and down the court, he's fine, doesn't bother him. When he tries to guard another player, when he moves laterally, or when he rotates his hip, he develops significant pain in the right hip, although he was actually having some symptoms on the left side as well. Now, he had a prior history of some low back issues and some hip pain, and the interesting part was that his mother was a physical therapist, and she was trying to stretch him out because his hips were so tight and his hamstring was so tight. He was not a very happy camper. He did not like his mother doing his stretches. And here's part of the reason why. So this fellow, spine looked great, gait looked pretty normal, very limited range of motion in his hips, and particularly pain when his hip was flexed and externally rotated. Simple, plain old x-rays showed, and I'll show you two slides of this because you might not be able to see it. This fellow had somewhat aspherical femoral heads. You can see it the best in the upper left part of the screen. This fellow did not have round femoral heads. What was happening is he was impinging. He was pinching his femoral head to the point that he had actually fractured the upper acetabulum, if you can see up here. I'll have the next slide shows an arrow. His bone scan showed increased uptake right at the area where he was having the impingement. And on the other side, it was so chronic and long-standing that it had actually started to significantly calcify. Here's a close-up of that fracture. It literally had probably been broken off for a while because it's actually fairly well corticated. So this is a fellow that is not going to respond to stretching out by his mother, the physical therapist. it really needs to be fixed from a surgical perspective. So this fellow's buttock pain was because of his femoral head and because of his fractures. So he underwent surgical resection of the fracture, osteotomy of the femoral neck, and basically realignment. And it took about 12 months for him to recover. At about 12 months, he was fully returned to his usual activities. Our last case before we get to Q&A is a case of a 45-year-old dental technician. And this fellow is a native of Russia and very, very stoic, comes into the office with really fairly minimal complaints. It shocks you sometimes when a patient like this comes to the office. Runs his own dental lab, so he missed absolutely no days of work whatsoever, sitting at his bench, doing teeth and whatnot. He had developed acute severe symptoms into the left buttock and was basically unable to stand straight. So this fellow on exam is stooped over. He can't become upright. He has a severe trunk shift to the right. Extension was essentially impossible. He couldn't do it. He could sit. If he got in the right position, he could sit. I mean, he would be relatively comfortable. His neural tension signs were very positive. He was getting radiation shooting out into his posterior leg almost with anything we did. Now, this fellow had been seen by a chiropractor before he came to see us, and it had a CT imaging study done, so we chose to just use his CT as our primary diagnostic tool rather than putting him through an MR. And what's important on this case is that this fellow had what we call a free fragment. He had actually broken a piece of the disc off, and it was floating in his spinal canal, basically settling on his S1 nerve root. So on this fellow, typically the usual and customary, if I asked 10 surgeons in a room, 9 of them would be sharpening their blades, waiting to go in to take this out, because it does have a higher incidence of requiring surgical treatment. This fellow was very stoic. He was not interested at all in any type of a surgical intervention, and asked if I would assist him in trying to get his symptoms under control without him resorting to surgery. So he was diagnosed with an L5 S1 Radiculopathy with a free fragment. He had 2 injections of the S1 nerve root and had virtually complete resolution of his symptoms. He came and saw me about 9 months later and asked if it would be safe for him to go with his daughter skiing in the mountains. And after examining him and making sure that everything looked okay, knowing the data that suggests that 75% of disc herniations like this will resolve in 6 months if you redo the MRI scan, I opted to allow him to go and ski, and he had a lot of fun with his daughter. So that's the end of our cases, the end of what I wanted to review with you all. Hopefully that doesn't make your head spin a little bit. But I'd like to go ahead and answer, any questions. I'll bring up one of my favorite Mark Twain quotes, and that is that I'd be happy to answer any questions, but I might say I don't know. So do we have anyone who has any questions for us?
Yeah, hi, Tony. It's Lou Levy.
Hi, Lou.
First of all, just wanted to thank you so much for joining us this morning, and that was a really great talk. I guess one question that I would have, you've been just such a great supporter of our program, and as you know, one of the key features of the Best Doctors Interconsultation is the clinical intake that we do when the member is contacting us. And I was just wondering if you had any thoughts around, when you're reading through the reviews, if on a fairly consistent basis you're noticing, boy, I wish they had told me this, or I kind of got the picture, but I don't totally have the picture, and I just wonder whether if they had just spent more time kind of delving into this, because we're always looking to have disease-specific templates and profiles within our CRM system, and, there's always an opportunity to kind of further refine what we're doing. So I didn't know from the standpoint of an expert whether you thought there were some things that kind of came to mind.
Yeah, actually, I usually don't see very many big holes in the intake, in the information that you derive from the member. Typically, it's getting to the essence of what the doctor's evaluations are. That's sometimes challenging. Part of the intake process, when talking to the patient, is sometimes there's it's almost like being a detective, where you've got, and I see this not uncommonly in cases, where you'll get a set of records, and then you talk to the patient, and the patient's descriptions are different from the records that you see.
Right.
They'll describe an evaluation with somebody else that you don't have any record for. And I do see that on a not that infrequent basis. And I think it's something that when you're doing the intakes, that you have to delve a little bit further and say, well, wait a minute, I don't have any record of this. What was that evaluation for, or what kind of problems were you having 6 years ago or 3 years ago, or what kind of trauma was that, or those sorts of questions, to delve a little bit further into evaluations that you might not have available records, and that's really about it. Most of the time, the case summaries are really very good. I'm very pleased with the case summaries that come in. My biggest challenge is making heads or tails of some of the examinations that are done.
Right. Well, thank you. That's very helpful.
Uh-huh.
And I didn't know whether other folks had any kind of questions.
I had a question about case 5. Was that injury on the 15-year-old? Was that injury maybe sports-related, or was that something that was congenital?
No, it was related. It was congenital. And what happened is that as he became more active, and as he got into other activities, so, running around or cross-country did not bother him at all, because his hip was moving in a single plane. It was only moving in one direction, so he wasn't pinching it. So he really didn't have, now he would complain to his mother that his hips were bothering him, and she would look at him and stretch him out and say, oh, you're tight, stretch your hamstrings. The kind of thing that you would say to your kid, okay, you're growing, you're 14 years old, he was becoming more and more active. He starts getting into basketball because he's grown and he's tall enough that now, he can play basketball reasonably well with the other kids. But the load associated with that is what made him symptomatic. So that kid was born with whatever his problem was.
Thank you.
Any other questions that folks might have? All right. Well, thank you so much. Really appreciate it. And just wanted to thank you again, Tony, not just for delivering our global grand rounds today, but also just for your ongoing robust support of our program. It's really appreciated.
Boy, I don't know. You guys must be signing on a lot of clients, because there sure are a lot of cases.
We are, and actually over the past 12 months, there's been a lot of activity, not just from these large self-insured employers such as Boeing and Microsoft and Home Depot and PepsiCo, but we've also had tremendous interest in the carrier space, and all of a sudden you begin to have conversations with people where they're not talking about their 60,000 employees, they're talking about their 3.4 million members walking around with their Blue Cross Blue Shield cards, and we're like, oh, okay. So, so I think that we are, as you have pointed out, we've been quite busy around here.
Wow.
But it's all in a good way.
Yep, sure.
So
sure.
Thanks again, Tony.
Excellent.
I know.
Okay, everyone. Well, thank you for having me. Take care now.